Well, good afternoon to everybody, and welcome to our first weekly COVID update for 2022. I hope you all had a good break and are ready for the new year. And let's hope that it's going to be a very much better year COVID-wise, certainly as compared to 2021. Certainly, we're starting off in a good space, and I'll show you right now. Okay, so when we look at the epidemic curve, this is our fourth wave over here. You can see it's a very steep upward trajectory of the epidemic curve, steeper than before, very much more infectious virus than we've had before, reaching levels much higher, in fact, than all our previous waves. And I'm sure you all know of it, so many people that have been infected, but not necessarily that ill with the Omicron-driven fourth wave that we've just experienced. So it's a much more acute curve, much narrower, steep upward and steep coming down again. But the important thing which I did want to kind of show to you and demonstrate is that if you look at our first three waves, the hospital admission gray over here follows very closely the epidemic curve of the cases. Cases and the hospital admissions seem to kind of go more as hand in hand. The fourth wave, however, there was a so-called uncoupling of the serious case of hospital admissions as against the case. The cases were very high, hospital admissions very much lower. And certainly the deaths were also considerably lower than what we experienced in the previous waves. So this was a characteristic of the Omicron-driven fourth wave. Very contagious, high levels achieved of cases, but very much milder. So I think this is pretty well known, but just to show you what it looks like graphically. Giving you a slightly new dashboard that we've had before. This is the NICE dashboard. This is the last 24 hours. Yesterday, 5,668 new cases, still 119 deaths, but this is somewhat of an artifact because deaths are reported towards the latter part of a curve. And this is where they appear to be in a way artificially higher because deaths are reported very much later during the epidemic. And a 14% positivity rate, in other words, the percentage of tests which are submitted to laboratories which come back positive, which again is a good indication of the extent of the epidemic. This has come right down from about 35% positivity rate, I guess about a month ago, down to about 14% and sinking fast. So just to compare the Omicron-driven fourth wave as compared to the second and third waves, as you can see, the number of infections considerably higher, 3 or 4 times higher than Delta and Beta, or 2 or 3 times as higher than Beta and Delta, the number of cases. Hospital admissions of these cases, considerably less, 5% is against 13.7% and 19% for the Beta. And of the hospital admissions, far fewer were severe in the Omicron. 28.8% of hospital admissions were classified as severe, as against 2/3, 66.8% of in the Delta of hospital admissions were severe, and again reflected in supplemental oxygen usage. And also the hospital stay. The average hospital stay for Omicron was about 4 days, half of that of Delta and Beta. What was also noticed about the fourth wave was that percentage-wise, proportion-wise, children and adolescents were more affected than in the previous waves. This might be a reflection of the fact that children and adolescents, the vaccination coverage, of course, with children under the age of 12, there's no vaccination coverage, and 12 to 17-year-olds, as I'll show you just now, very, very poor vaccination coverage. So that might be one of the reasons why it was relatively affected the younger age group more than older individuals. So this was the personality of our fourth wave. As I say, higher transmission, a very infective virus, number of cases very much higher, but milder. In contrast to this, what we're really hearing from the news media and what's happening in the Northern Hemisphere and the developed world, the industrial world, that's really where they are really kind of suffering now from the Omicron-driven some cases fourth wave, some cases fifth wave, depending on the country. As you can see from this map here, this is where the concentration of Omicron viral activity is in Europe and the United States, far less in the Southern Hemisphere. So why is this? And I think we really kind of need to analyze some of the reasons. As you can see, I think reflected here quite graphically, a country like Denmark, it's really totally counterintuitive, not really what one expect. Denmark, one of the countries with the very highest coverage in the world, over 90% full coverage of their population. And have a look at the number of cases, one of the highest in the world. Really kind of totally unexpected. United Kingdom, also high vaccination, over 70%. Norway, the 80 to 90% coverage as well. And here we are in South Africa. This is in the middle, or towards the latter part of December, when we were in the height of our fourth wave. And you can see significantly lower than these countries with much higher vaccine coverage than what we've got. And again, just to compare United Kingdom versus South Africa, just look at some of these. And I've updated, in fact, to yesterday. Our populations are more or less similar. United Kingdom slightly higher than South Africa. So I've adjusted it per million. And the cases, we're at 120 cases per million population, 1/20 that of the United Kingdom at the moment, 2,294. The deaths, as I remember, this is a bit distorted because, as I say, our deaths are towards the end of the epidemic. There's a bit of a lag reporting deaths. So it will be a little bit kind of artificially higher than what one would expect. But let me point out the median age of our population considerably lower than the United Kingdom. This might be one of the factors. I'll come to it just now. And of course, our vaccine coverage considerably lower. We're now at 29 about 30% coverage compared to 70%. So you can see that South Africa, we appear to have, with the Omicron, a very relatively mild. Of course, Omicron, even in the Northern Hemisphere, is a milder disease compared to the Deltas and so on. But even comparing our Omicron wave as compared to what's happening in the Northern Hemisphere, where their hospitals are being overstressed, overburdened, not being able to cope with the kind of influx of cases, enormous numbers. And we weren't really, our hospitals were not really stressed hardly at all. So why, in fact, is there this? What could be the factors? And I think it's really important to kind of try and analyze why we experience a very much milder, in fact, even milder itself, and even more milder than what is happening now in the Northern Hemisphere countries. So let's look at some of the factors. First of all, we have to question, are we certain that there are these differences? For one thing, we know that in the Northern Hemisphere, industrialized countries, they're testing far, far more than we are. So the testing volumes might artificially look as if there are more cases because they're just simply testing much more than we are testing. Our testing for contact tracing and so on is just about zero. We really test either incidentally when people come into hospital, and that itself, of course, can also distort the figure because it might look a lot higher, the hospital admissions, because people who come in for things unrelated to COVID get tested as a routine, and they might be incidentally found to be positive, but not being admitted to hospital for COVID. So that might also be a source of distortion, that these figures are in fact not totally accurate. And of course, access to healthcare facilities. Much of our population don't have good access to healthcare facilities. They may even have mild, even moderate symptoms, but just don't get to a healthcare facility and therefore are simply not recorded as such. So these could be some of the reasons why we might look as if it was relatively mild. Testing volumes are lower, access to healthcare facilities is much lower, and so on. But I think we do need to recognize, because of the stress on the hospitals and so on, that we did, in fact, have a mild epidemic to what's going on in the Northern Hemisphere. And we need to kind of look at what it is. So we look at the human factors and we look at the viral factors. Now, with regard to the human factors which might govern why we had a relatively mild epidemic, the most important is the population immunity. I'll deal with that just now. But the lesser important factors which may play some role, The younger age, as I pointed out earlier, our median age 27.6, as against, for example, the United Kingdom 40.5. This would be similar in other European countries. And we know that the disease is more serious in old individuals and the young individuals. That may play a role. Probably not a major role, because we did see quite significant illness in young individuals as well. The climate, we're of course in the middle of our summer season. People are outdoors more. There's a holiday period as well. People were outdoors and beaches and so on, and sunlight outdoors. And this may be a fact in terms of human behavior, lowering the risk of transmission as compared to the winter in Europe. And also, but importantly, adherence to non-pharmaceutical interventions. We know that in Europe, United Kingdom, many of the European countries, they've all but abolished mask wearing, big crowds, and so on. And South Africa, although we're not perfect by any means, we are probably a bit more stricter in terms of these infection prevention measures than what is the case in many of the European countries. But the most important thing really is population immunity. This probably is the key why we experience a less epidemic compared to them. Now, this might seem very counterintuitive. It's because population immunity is due to vaccine coverage, was vaccine-induced immunity, or natural immunity, people that have been infected before and develop a natural immunity after they recover from infection, or hybrid, a combination of both. And we know that people that have a natural infection and then are vaccinated, they get a very good immune response. So all of these things would contribute to population immunity. Now, if we come to vaccine coverage, this really is counterintuitive, because we really can't ascribe our population immunity to the amount of people that are getting vaccines. This has really been, and I'll go a couple of slides in this has been disappointing, really disappointing. These are the number of doses administered over the last 24 hours yesterday, 86,613. You remember back in August, we were looking at a target of between 250,000 and 300,000 doses per day if we wanted to reach a herd immunity level. We're now only 86,000. So the vaccines are there. It's not a shortage of vaccines. It's a shortage of people coming to get vaccinated for various reasons. And in fact, even in our highest risk, the elderly, the 60-plus year age group, vaccination coverage is far, far from what we need. People that have been vaccinated in this age group are 66%. In fact, if you look at people in that age group who are fully vaccinated, it's only about 60%. 40% have not been fully vaccinated or not vaccinated at all in the higher age group. So really, vaccine coverage can't really be the answer. If we look at our vaccination data, I do these slides on a regular basis, we can see fully vaccinated of the adult population, 40.7%. Total individuals who vaccinated, 45.4%. Now, the global vaccination coverage worldwide is over 50%, more than 50.1% globally. The entire world has received vaccine, and we are lower than that. The adolescent age group, 12 to 17 years old, 16%, a really pathetically low figure of the adolescents that have been vaccinated, very, very low. Boosters have been, and there was a big clamor for boosters. Only 12,443 doses have been administered as the third dose to people that have been vaccinated 6 months ago. So really, the vaccination status itself can't be the key to why we have a milder illness relative to the Northern Hemisphere. But what probably is the key is that it appears that a large number of individuals have got antibodies to the virus. If we take various samples, and various studies have been done where they've sampled from blood transfusion or random sampling of the population, or they look at households and follow them up prospectively. And this is going back all the way back to September. Already they were demonstrating that 60 to 70% of the population had got antibodies. Now, it doesn't mean the antibodies are necessarily all protected, but it does reflect a high level of natural immunity in our population. This is probably closer now to about 80%. So that is natural immunity hybrid immunity, that's natural plus vaccine, and the contribution of vaccine. And this probably is why we are seeing, that's probably the main factor, why we are seeing relatively milder infection, or milder disease, I should say, in this country compared to the Northern Hemisphere. Now let's finally look at viral factors. Is Omicron, in fact, a milder virus itself? I'm going to just rush through this, but I'm going to deal with this maybe a bit more detail next week, just because we may be running out of time. But there's been a lot of studies now showing that Omicron is intrinsically a milder virus, a less potent virus, a less virulent virus. And of course, the big question we all want to know, and is this now the gateway to the evolution to a milder form of coronavirus, to what you call endemic coronavirus? You know, we've got those 4 coronaviruses who cause the common cold. Is this now the SARS-CoV-2, the ones causing our present COVID? Is this now evolving to become a milder virus? And I'll just go through some of this to kind of show you some of the experimental work, which is demonstrating that it is a milder, less potent virus. This is done in cell culture, and it shows that this is the Delta, our previous variant. And you can see it's causing a lot of damage. These are plaques where the virus has killed off cells in cell culture, the white areas. And you can see this extensive damage to the cell culture by Delta, and very, very much less with Omicron. And also giant cells, which are, again, one of the poor prognostic signs of damage to the lungs. This is the ancestral strain, the original ancestral strain, before we had our variants, the 614G. And you see quite extensive giant cell formation, very, very much less so with Omicron. These are in laboratory mice which have been genetically engineered to be susceptible to our coronavirus. You can see with Delta, there's extensive damage to the lung tissue, as compared to Omicron, where the architecture of the lungs has been largely preserved. So we see Omicron does very much less damage in laboratory animals to their lungs as compared to our previous variant, compared to Delta. This is just a table showing all the kind of various studies which have been done, and now there are more and more of these studies showing that Omicron is a milder virus. There's a lovely story about rabbits, about myxomatosis in rabbits in Australia. I'll keep that for next week. I'll keep you in suspense. So you will come back again next week, and I'll deal with that a bit in more detail. So I think I'll end it here, because I think I want to just go through some of the questions, and I'll deal with that story in a bit more detail next week. I had a number of questions with regard to the boosters. There's one questioner, somebody sent in that they want the Pfizer as their boost. Just to remind you, the people, that healthcare workers who've had the one Johnson & Johnson should get a second dose of Johnson & Johnson at least 2 months after they receive the first dose. It doesn't matter if it's 3 months or 4 months or 5 months, 6. In fact, at 6 months, you get an even better immune response. But at least they should have that second dose of Johnson & Johnson. People that had the Pfizer at least 6 months previously should get the booster. Now, between the Johnson & Johnson and the Pfizer, there really is not much. People have been kind of, I think, affected by the fact that Pfizer has been used very widely in Israel, in the United States, the United Kingdom, and so on. But really, the Johnson & Johnson is approved by the FDA in America, approved by us, SEPRA. It is a very effective virus. I personally have had 2 doses of Johnson & Johnson, nothing more, nothing less. It has a slightly different kinetics in the way that it produces immune response. Maybe next time I can also look at the comparison between the two. But really, we can't say, or the question says they believe that Johnson & Johnson doesn't work against Omicron. That's totally untrue, totally untrue. Johnson & Johnson works very well against the Omicron variant. In fact, as well as the Pfizer. The Pfizer gives you a higher in neutralizing antibody response. The Johnson & Johnson probably gives you a better cell-mediated immune response. So there's nothing really to choose between the two. And there's no preference between those. I think the important thing is just to get that booster when you are eligible for the booster. There is another person that asked about the mutants. I'll deal with that more. Why these mutations? Are these mutations? Do they reflect a milder virus, or do they reflect a more severe virus? I'll deal with that in more detail. I don't want to rush through it now, just to explain it better then. And then lastly, somebody asked about if they're in a high risk category. And we know that people that are immunosuppressed, whose immune system is suppressed for various reasons, either they are transplant patients and on drugs for that, or they're cancer patients on drugs for that, or they're HIV patients, they should get a booster dose over and above the regular dosage between at least 1 to 3 months after their last dose. Who falls into this category? As I said, it's those individuals who are quite severely immunosuppressed. This person has got a thyroiditis, which is inflammation of the thyroid gland, as well as psoriasis of the joints. Psoriasis is skin disease, which can affect the joints as well. That really is not really in the same category. People that are on low-level steroid treatment, for example, people with other diseases, milder diabetes and so on, hypertension, these aren't categories which are regarded as being immunosuppressed for the booster. The booster dose is really for people that are severely immunosuppressed, either with advanced cancer, and cancer chemotherapy, transplant recipients, advanced HIV, and so on. So I'll leave it there, and wish you all a great day and a great week, and look forward to seeing you again next week for next week's midweek COVID update. Thank you for listening and watching. All the best. Bye.